All right. Well, welcome everybody to the. I guess this is the second semi-annual Spine Fellow case presentation rounds. This month, or this rounds, we have a presentation from Cayuga and also from St. Luke's. Sabrina, are you the one from Cayuga presenting?
I'm not. No, I'm from
Oh,
Memorial Hermann.
oh, my apologies.
That's okay.
Is there somebody from from Cayuga on? Okay. Well, there is somebody from St. Luke's on. So, Paul, why don't you? Paul first is a spine fellow at St. Luke's University Health Network in Bethlehem, Pennsylvania. He is about to graduate on Monday. So I asked him to present today. And so if you would be able to share your screen and present, and then we get to ask him questions.
Cool. Working on the share screen. All right, everyone good?
Yep, good.
Good. All right, guys. Well, thank you all for being here today. I appreciate the opportunity to have the platform to sort of discuss my clinical decision making and reasoning from start to finish for a lumbar case. With that said, these slides will be sort of quick and dirty just to get to the point where we can discuss things at the end. And with that, let's get going. So my patient was a 68-year-old semi-retired psychologist. Can you hear me?
Yeah, could you minimize the little box at the bottom right hand corner?
Yeah, no problem. There
Thank
you
you.
go.
All right, continue.
That's an easy one. So my patient was a 68-year-old semi-retired psychologist who presented direct access with an acute exacerbation of her low back pain starting in November of 2024. She reported a 5-year history of this back pain starting on the right side and low back. Tried self-managing with the gym in January of 2025, but this eventually led to an exacerbation down her right hip towards her lateral knee. This prompted her to go seek out a PCP in late January, who then referred her to hip orthopedic surgeon. Once she saw the hip orthopedic surgeon in early March of 25, he provided her with updated imaging and then eventual referral to orthopedic spine surgery versus orthopedic PT. Those images revealed a positive grade 1 anterior listhesis of L4 on L5, as well as right greater and left intervertebral space narrowing at L4, L5. Her past medical history is significant for osteopenia. She had a prior cardiac catheterization in August of 24, a rectocele and cystocele, amongst other things. Her red flags: no major cardinal signs, no history of cancer, but she does report night pain as one of her chief complaints, so that's to be noted. Her meds are as follows, as you see there. It's important to note that her initial mechanism of injury occurred in 2020 while she was performing a yoga routine, twisting to the right, which led to a pop. And since then, she has not felt the same. This, of course, led to her seeking out orthopedic manual therapy, chiropractic, pelvic floor PT, 2 bouts of outpatient PT also, all of which failed. She has not been able to get back to her original baseline. Sorry, computer's acting a little slow. There we go. Her chief complaints and limitations are as follows. She reports right-sided lateral hip burning to the outside of her knee, which gets from 8 to 10 worse at the end of the day. Since the aggravation, she's also unable to lay down and achieve any position of comfort, which disturbs her sleep, which is her chief complaint, of course. She's unable to transition, squat, lift her grandkids, sit for prolonged periods, which then, of course, leads to right-sided hip and leg pain when she rocks her grandkids to sleep. She does note that sitting is better than laying down and that standing helps. Functional comparable signs, things that we're going to be checking in on from time to time throughout the plan of care to see if she can improve her ability to squat, sit or perform transitions from sitting to supine or sit to stand, that she doesn't peripheralize with prolonged sitting, and then, of course, that she's able to sleep, but this is something that is sort of challenging to measure within the clinic. All of which will hopefully lead to improved participation in her ability to return to yoga, water aerobics, and her gym routine. Whoops. In terms of our reasoning and hypothesis, just to spend a few moments here, it's important that we spend a little bit of time discussing potential pain phenotypes. Adrienne Lowe did a lecture to our network back in 24 who discussed pain pies and some of the pain phenotypes that occurred with that. Within our fellowship, we've utilized those pain phenotypes as almost like a compass for us to help guide our hypothesis as well as our treatment-based decisions. So with this case, the top potential pain phenotype that I'm considering prior to my examination, of course, was that she was a potential nociplastic pain, someone who presented with potential chronic pain syndrome. And the way that I was going to rule that in was utilizing SMART et al. Criteria from 2012, considering if she had proportional or non-proportional symptoms, widespread or diffuse symptoms versus local, and then if she had any yellow flag or cognitive affective related behaviors towards her symptoms. And that would correlate well with my top ICF-based diagnosis, considering George and his clinical practice guidelines, looking at low back pain with cognitive affective tendencies. From there, I'd work my way down my differentials, considering more neurogenic phenotypes, which would correlate well with radicular leg pain, as you see towards the right of the screen. And then from there, if we weren't able to achieve positive straight leg raise or slump signs, we would then consider a nociceptive type of phenotype, considering right referred leg pain or someone who has mobility deficits. And then from there, if the spine was able to be ruled out via my examination, then we start to consider other types of sources of pain, more peripheral, like right hip, SIJ, thoracic spine referral patterns, which would correlate well with those diagnoses and hypotheses as you see towards the right. And then get more specific with potential L4, L5 spondylolisthesis stress responses, thoracolumbar compression fractures, abdominal aortic aneurysm, and then, of course, if all else fails, when things are non-mechanical, consider either cancer or some other pathology, and then from there refer. So with all that, that would then lead us to the point where we would utilize a treatment-based classification, a clinical practice guideline, or think about utilizing the low back decision tree from Joe Godges and his colleagues. So at that point, prior, going into my exam, I wanted to take a point to look at my outcomes. We utilized photo at St. Luke's, which predicted this patient to get up to a 70 out of 100 score and within 11 visits. And we also utilized a Starkback tool to help prognosticate. Her score was a 5, and the thing that I'm noting most is her psych score being a 3, which puts her at a risk of 2, being moderate, predicting her to get to 8 to 12 visits. The psych score does not predict nociplastic pain, but more or less someone who may present with catastrophic thoughts or catastrophization, etc. So from there, we went straight into the exam, as my considerations follow. Because of her history with cardiac catheterization, wanted to be sure to check vitals, make sure this wasn't an emergent case where she needed referral or triage further. Luckily, her vitals came back within normal limits, being BP and SpO2, heart rate, et cetera, as you see here. So I felt okay to push on with the lumbar screen to rule that in or out. So I performed the lumbar active range of motion, which revealed that she was within functional limits in all planes, other than a minimal restriction with side bending right and rotating right, which actually produced her chief complaint on why she was here in the clinic. So that's to be of note. From there, I went to see if she had any type of real nociplastic or cognitive affective behaviors with movement in general after the lumbar screen. So I had to perform, the whole lower quarter screen from there. And the only thing that came back positive was she had a chief complaint reproduced with a squat, but she didn't have any apprehension or catastrophization towards that. Thinking in terms of my neuro exam to further rule in my phenotypes, she was normal limits with myotomes and dermatomes and didn't really have any hypersensitization towards my tactile inputs. And then further ruling in my phenotype of, as we see later, and ruling out neurogenic phenotypes, she was negative for slump and straight leg raises, and her reflexes were within normal limits as well. Despite all this, to continue to confirm how I wanted to treat my patient, I went through repeated motions exam. And things to be noted was that repeated extension and standing improved her symptoms, mostly noted that she improved her ability to side bend right and rotate right, as well as slight improvement in L1, L2 myotome. because I had a cancellation with my patient after this exam, and I had a student at the time, I was actually able to perform a second round of this just to confirm my hypotheses and the way I was going to approach my patient. So that second round actually, after performing repeated extension and standing, led to an improved ability to squat with less discomfort and improved symmetry, which I thought helped solidify the fact that I wanted to go more towards extension. Another consideration was that, to further put, was that she did not have any pain production when she performed a sustained press up in prone. So that, along with the fact that she had palpation, based on my palpation and joint assessment, she was hypomobile at L3, L4, which reproduced some of her pain. I felt that extension was the way I was going to go with my treatment. Other notable findings were that she was negative for the ESIJ. She had a positive fader, an active straight leg raise sign, as well as a supine to sit test with the leg discrepancy noted. But like I said, I wanted to rule in the spine first as the main source of symptoms. So as we're getting, here we go. Whoops. So my diagnosis based on my examination was that clinically she presented as a subacute low back pain with referred right leg pain, secondary to mobility deficits. Her pain phenotype was nociceptive, as she was negative for the SMART et al. Criteria, as well as negative for straight leg raise and slump signs for the neurogenic criteria. Her severity was low to high, worse towards the end of the day. Stability is slightly unstable. In terms of a treatment-based classification, she was a direction-specific exercise. Thinking about Phil McClure and his 4 elements of movement classification, we utilize that at St. Luke's to help guide our intervention. So from there, she is clearly a mobility focus, as her lumbar spine mobility was restricted with right side bending and rotating right, as well as the fact that she had hypomobility and pain with segmental testing at L3 and 4, which were each comparable signs for her pain. From there, because of the improved comparable signs with extension, she is a directional preference towards extension. And if we're thinking about a McKenzie classification, she was a derangement, as her pain was sort of, while she was side bending right or rotating right, the pain was variable in mid ranges and at end ranges. With all that said, our intervention that we provided her was a self-mobilization via McKenzie repeated extension and lying, or a potential repeated extension and standing. The patient self-selected repeated extension and lying on the initial evaluation. We also provided her with posture education and use of lumbar support. With all that noted, our prognosis is good due to the good initial evaluation response. The fact that she had a directional preference also bodes well based on May in 2018, and the fact that she's coming direct access is a high likelihood for high therapeutic alliance as well. So with that, our plan is to see her 1 time a week for 4 weeks. Within Pennsylvania, we're only allowed 30 days to treat, and the fact that this patient was coming 50 minutes and had to watch her grandkids 3 days a week, she could only come once. So that's sort of how that went in terms of our plan. So here are our treatments. There's a lot of information here. I apologize for the clutter, but it was hard to sort of get everything smushed in. On first follow-up, our day 1 focus was towards mobility because she had a good response to extension. So I assessed the home exercise program, which she was performing fairly well, but still upon baseline assessment was still having pain with lumbar side bending right, which was producing her comparable sign. So we continued to assess her ability to perform extension as she was performing it pretty well at home, like 8 times a day, every 2 hours. But she wasn't performing the repeated extension and standing, so I wanted to see how that would go. When she performed it, it peripheralized down her lower extremity, which kind of gave me a little, roadblock potentially. So my thought was, because we reached end range extension, that we would potentially change to go lateral with our directional preference. But the patient suggested we check out her hips, and she was concerned about it. So because she had a positive fader on the initial evaluation and hypomobility at her hip, I decided to go with a repeated half kneel extension to try to alleviate that or improve mobility there. This, as a result, actually led to better pain within the session, but upon reassessment of comparables with side bending right, it had no improvement. So despite this, we ran out of time within that session, so I kept everything the same with the home exercise program, but added the half kneel for pain relief, thinking that maybe that half kneel was a potential lateral component there. So on day 2, when she came in almost a week later from the first follow-up, our focus was still mobility, But what was nice was as she continued to perform her home exercise program, she was able to achieve pain-free sleep, which was one of her main comparables. Upon assessment of her baselines, still having pain with side bending right, but today without peripheralization, which was kind of nice. So from there, because of last session, I wanted to go lateral and see what would happen there. And because she had hypomobility at L3-4, I went forth with some grade 3-4 unilateral PA mobilizations. I performed 3 bouts of that within the session, which actually reproduced her comparable sign, but also led to a cavitation after the 3rd bout. From there, I reassessed her ability to perform lumbar side bending right, which now was pain-free at end range, so we're thinking we're doing pretty well. Upon her returning out of that end range side bend, she still had pain coming out of it. So from there, the patient actually suggested if she could utilize her core, I guess because of her prior PT experience. And when she activated her core, she was able to perform side bending right full range, which shifted our focus from mobility more towards a motor control in session. So for the last bit of that second day, we performed a lot of TRA progressions to the point where we were performing glute and TA co-activation with single leg bridging, but this reproduced her main comparable pain again. So from there, this prompted me to try to go through some diaphragmatic breath work, which improved her symptoms. And so from there, I added a lot of transverse abdominal work and diaphragmatic breath work for her home exercise program, keeping it mostly the same. From there, on day 3, she came in 2 weeks later. There's a big gap between day 2 and day 3. And during that time frame, she was still compliant with the home exercise program, still pain-free with sleeping. And without discussing things with me, she decided to try yoga. While she was at yoga, she injured her left knee, which she wanted me to take a look at, which led to a hip-knee tangent. Prior to me doing that, though, I did assess her baselines, and she still had pain with side bending right. This time in mid-range is only coming out of that side bend, which still, we're thinking is a continued motor control issue. But despite this, I spent some time looking at her hip as per her suggestion, and she had a positive overs bilaterally, which I addressed with a ton of hip mobilization to try to address that, which, just for yucks, I assessed the side bending right after that mid-session and still had pain, so no effect on our main comparable again. So because she had pain with single leg bridging on day 2, I decided to see if I could load up the posterior chain with a lateral step down, which actually reproduced a comparable sign. Because of this, I wanted to see how it would affect if we could modulate her pain with fatiguing the glute. So with a ton of clamshell and glute bridges within that 3rd session, after performance, she was able to then side bend right fully pain-free throughout full range of motion. So I'm thinking we're in great shape. Kept the home exercise program and added glute bridges. Finally, at day 4, she came in 1 week later, and she felt like she was able to be discharged. She tried yoga and water aerobics, all of which were pain-free, and she wanted to strengthen independently at her gym. Her comparables at that point were all negative. She was able to sit, squat, and lift 40 pounds, as well as perform transitions when she uses her TRA, but still reported some pain with vacuuming, which she attributed to as she gets stronger, should be better. Her reassessment in terms of lumbar active range of motion was within normal limits, especially when she uses her transverse abdominis for that right side bend. Her myotones were normal. Plank, she was able to perform 32 seconds. Outcomes noted are that she reports an 85% global rating of change. Her photo score improved to 75, higher than predicted. Start back 1 and psych score 1. From there, I told her we could follow up as needed and provided my email. If she had any questions, of course, she could feel free to reach out. And with that, guys, I appreciate your attention for that time and any questions.
Actually, I do have a question. On your second visit, you were doing some mobilizations and it helped. Yes, you got a cavitation, but what made you decide not to do a manipulation at that point? Or the other part of that question is, do you think if you chose to manipulate on the first visit, do you think that would have sped up the process to only 3 visits being needed?
Yeah, absolutely. Great question. So Because of her history of failed treatments with orthopedic manual therapy and chiropractic, I did not want to go right to the manip just because I wanted to create a lot of self-reliance and resiliency for her to self-treat to reduce her potential towards chronic pain. So with that, I wanted to see how self-mobilization would be affecting her so that she could self-manage. But I think in retrospect, if I could have manipulated initially, considering she didn't have any pain past her knee, I think I could have improved the main comparable for side bending right a little bit sooner, at least in terms of achieving end range. But then from there, the other thought was, should I have considered motor control more efficiently or sooner? Um, that's the point of this, right? I think after I was able to achieve end range extension on the initial evaluation, I probably would have gone through and done some motor control assessments and see how she was doing with TRA. So I don't know. Is that sufficient, would you say?
That answers my question. Thank you.
You're welcome.
Who else
Hey,
has
Paul,
questions?
great job.
Thank you.
Hey, it's Sabrina from Memorial Hermann. Great job.
Thank you.
Just a question, and I apologize, I may have missed this, but you mentioned she had right-sided leg pain.
Correct.
And then how often was she getting that leg pain?
Good question. Yeah, she was getting it daily. She was getting it mostly when she was sitting, rocking her grandkids to sleep, but also having that discomfort with squatting and obviously any type of like side bend or motion to the right, which I think correlated with her inability to sleep, right? So that if she was a side sleeper, she was getting some of that leg discomfort that was limiting her ability to sleep. So relatively frequent and daily.
Okay. And then her most painful lumbar segments were L3, L4, is that correct?
Correct.
Okay. And then I saw to look at the leg pain, you did a slump and a straight leg raise, and they were both negative.
Correct.
Okay. Did you ever, I'm not too sure the pattern of her pain down her leg, but just given that those were the most painful lumbar segments, did you ever think about a femoral nerve tension test by chance?
It's a good question. So it was like a lateral type of distribution. So I guess I could have. I mean, she did have pain with an Ober's test, so a lateral femoral cutaneous nerve could have been something I could have considered. So yeah, I guess that makes sense. But in terms of a femoral, um, yeah, I wasn't seeing most of that correlation in terms of her distribution of pain just because it was more lateral.
Yeah.
But interesting.
Yeah, no, that definitely makes sense. That's why I asked, like, I couldn't remember if you had said, like, what her pattern was like, but just given, just like where her pain was in her lumbar spine, and then also given she had a negative, slump and straight leg raise, I would be curious about the femoral.
Yeah.
But if the pattern is different, obviously that may not make sense, but just would be curious about it.
Yeah. Yeah, and the thing that was challenging too was the foraminal space narrowing at L4-5 also. I mean, there was some clear imaging findings which could have skewed me a little bit. But luckily she didn't have any of those neurogenic type of slump or straight leg raise signs. So I felt fairly confident that as she was performing a lot of those more central spine related movements that it was reproducing her pain. So yeah, I don't know. I think it's an interesting point. So
Cool. Well, great job.
thank you.
Hey Paul, how you doing?
Good.
I really liked it. I thought it was a great presentation. I wanted to get your thoughts on one thing though. I know direct access limited the amount of visits you would foreseeably have, but it seemed like the four-day course or the 4 appointment course was really productive. How do you reconcile that with some of the outcome measures that you took and the a data entry that specified this so many amount of visits? I think it was one was 11 to 12. What are your thoughts on that discrepancy?
Yeah. Oh, so the fact that it was more efficient rather than what data inputs, like I think the photo came back at 11 visits and the start back suggested 8 to 12. Is that what you're referring to?
Yeah.
Okay. Yeah, no, it's interesting. I don't know if it was just because it was efficient uh, with my care, me really treating comparables from start to finish and making sure that she was able to self-manage. I would say her self-management and her motivation to improve, and the fact that she was an active person who wanted to get better so that she could be with her grandkids and travel and do those sorts of things may have sped up the process in terms of the prognosis there based on what predictions were. So, because I was able to recheck comparables a lot and give her confidence that we were on the right track, I think that affected our outcomes being a little bit more efficient. And the fact that, again, to repeat myself, that she was able to self-manage fairly well without minimal input from me other than just guidance and a little bit of manual intervention, I think boded well for why we were so effective.
Yeah, absolutely. I thought it was interesting. I think it would be a very intriguing paper to look at. What do these outcomes tell us about how fellowship trained therapists address patient concerns in a timely manner? I guess that was something I kind of took away from it because it seemed like you were really efficient and really honed in on what the problem was that might have taken longer for a more of a generalist. So I thought it was neat.
Thanks, man. It's good to hear your
That
voice too.
that is a, very awesome point. And if we can be successful in getting a paper published in the next couple months, it confirms that consistently in two different samples over the past in 2022 and in 2024, um, of fellowship versus residency versus board certified without residency or fellowship training versus generalists. Residency and fellowship consistently get better effectiveness, and fellowship gets better efficiency. So it's pretty cool data. I'm just hoping I can get it over the finish line and get it accepted by, you know, somebody decent.
Hey, Paul. Great presentation. I really enjoyed you speaking about the patient presentation, how you treated her, and obviously, again, kudos to getting her better in the allotted time that you had. I was wondering, based upon her physical exam, and I think it was maybe day 3, where you started to introduce maybe some lower extremity strength or maybe some single leg specific activity, and she was having kind of her concordant sign during those exercises. Did
Right.
you consider that there was maybe like an extra articular hip pathology going on, like potentially come from her gluteus medius, or were you convinced that it was from the lumbar spine the entire time?
Yeah, awesome question. And this is, I think, where a lot of my focus in terms of decision making came. Was it the hip versus was it the low back? And there was a study by XPOS in 2019. I think actually it was XPOS study by Rosedale and his colleagues in 2019 who focused on exploring the spine first initially before ruling in any type of peripheral type of cause of symptoms being like the hip or the SIJ or any other type of cause. So by achieving a ton of being able to get the spine moving well. Once I did that with, I think, treatment 2 and the fact that she can control her symptoms a little bit better with motor control, I was feeling that we were on the right track. But because, yes, I mean, the hip was certainly in the top of my focus too because of her fader testing and limited mobility there from the initial evaluation. It's something that today I think still may lead to why her low back was not moving well, also because of how active she was and how she was with her grandkids daily. But I think when I have, because she had some mobility deficits there, could it have led to some glute compensations or weaknesses over the course of time, maybe adaptive tissue changes? I think so. But I wanted to feel confident that the spine was ruled out initially before going straight to the hip. And that's, just because it's something that is somewhat easy to reproduce and reliable in terms of lumbar assessments. I feel like we can rule in low back related pain fairly efficiently and effectively with repeated motions and joint end range achievements. And if from there, if those tests were negative, then I'm like, okay, great. Now I can go forth and think about the hip. The fact that her lumbar spine was still reproducing symptoms from day 1 to day 3, I didn't feel completely confident that her spine was still not a main cause. Because, as she improved mobility, then there was motor control deficits. Was motiflidae something that was related to her symptoms? Was, her poor activation with TA something related to her symptoms, right? But then we found, of course, that the glute was a factor as well. So something to keep in mind, of course. But yeah, great question. I don't know if I answered correctly or not.
It was well done. I mean, I think you were efficient enough in 4 visits. I guess if you wanted to be more efficient, you could have maybe addressed like some kind of isometric exercise for the lateral hip. I mean, you saw here that you did a clamshell and a bridge, and then afterwards she had improvement in symptoms. So it's simple exercise. I guess that could have been the one extra thing that you could add it on day 1, but you added it in an appropriate time, and obviously she got better in 4 visits. So kudos, well done. Well done.
Thank you.
All right. Any other questions?
Yeah, I was a little not confused. I had a thought in my mind at the beginning when you went to the diagnosis portion, when you went kind of through your differential list.
Yeah.
And you and I think, have kind of talked a little bit about this when we were last with each other in October. Um, I'm interested to know in your differential list, what kept you from adding in more of a structural diagnosis versus just low back pain with an impairment based diagnosis. You have some there. I see, I see some, but I'm curious your thoughts of what kept you from saying this was like spondylosis versus um, stenosis, or something that, from a clinical standpoint, you could reasonably assess.
Yeah, it's interesting. I think I'm so wired now to consider phenotypes initially as a guide to how I want to treat, that it's like kind of the first thing I think about is, if someone has chronic pain, someone who presents with, catastrophization and cognitive affective behaviors, you're going to treat that pain, that symptom completely differently than someone who has, nerve related pathology or someone who has a joint related pathology, right? So, and it's, to be less specific initially, because this is something that has been treated for 5 years with failed treatments from chiropractic and orthopedic manual therapy and prior PT, it was like, yeah, I think it's easy to say that it's the L4, L5 spondylolisthesis, right? It's easy to say that it could be something coming from the hip. But because, I'm sure she's gotten every single intervention under the sun, it was probably non-specific, right? It's not as specific. It was more non-specific. Maybe it's all the combination of things that are going on that's leading to her back pain. It's the cognitive affective issues. It's the mobility issues that were creating her symptoms that she just didn't understand how to self-treat, I think. And I think it's a challenge to just point it on one thing, and just really, because from there, do we want people to have surgery? Do we want people to catastrophize these imaging findings and then go down the rabbit hole of getting pain medication and then fueling that whole chronic pain type of society, right? Can we keep things a little bit less specific or non-specific and to just give them strategies so that they can self-manage, so that we can cut down on costs for these people? And I think that was sort of where my mind has been wired within the last 12 months or so. versus just saying it's definitely that spondylolisthesis, you know?
Yeah, no, I like your answer. I think the pain phenotypes as your first generalization is really cool. I like that framework that you're using, and thinking of it in those terms before you move on to your impairment based diagnosis. Um, I think I hear what you're saying about the avoiding the pain catastrophization and reintroducing the I guess more medical model interventions with a diagnosis that is more medically associated with those. So I think that makes sense versus what you're talking about here, which is um, globally trying to capture everything without producing that, I guess, fearful behavior. So I think that makes sense. I just wanted to know your thoughts. I don't disagree with the way you did it at all. I just wanted to understand your perspective.
I appreciate your question.
Actually, I have one more if you don't mind.
Yeah.
I think on the physical exam slide, it says there was a positive fader, or fadir, however you like to pronounce it. But did you do anything else to either rule in or rule out the hip?
Yeah, I mean, so the fader, she did have hypomobility with internal rotation, which kind of coincided with the fader. I didn't go through like a major type of like scour assessment or anything like that fully, just for the sake of time and the fact that she was getting a lot of her symptoms associated with the spine. The fact that she was there with a fader and I knew it was hypomobile, I feel like was enough for me, because it was obviously a positive finding, but it wasn't her chief complaint, right? It was one of those things that she had pain with it, but it wasn't the symptom that she was there for. So that was the other thing that led me more towards the spine versus the hip. And that was the deal for me. It was, because the spine and reproduction of symptoms occurred with active range of motion, as well as performing of like a squat, being a flexion-based movement, despite the fader issue there, it wasn't her chief complaint, the fader. And so I apologize for not stating that clearly, but that was sort of my reasoning.
Yeah, I think that makes total sense. Was her pain with the fader, I guess, like where was it in correlation to like where her back pain was?
Yeah. So the fader was obviously more anterior groin.
Okay.
Her back pain was more lateral, almost in like a glute TFL type of distribution, but also like potential ITB region. So
Gotcha. Yeah, no, I think that makes sense. I think that's fair for sure.
yeah, it's hard to fit all that stuff within 5 slides. So
I know,
yeah,
it's tough. And you're also trying to make it so that like it's not an overwhelming amount of info for people to digest and stuff to try and get just like a snapshot of the case. So I totally get it.
fair. Yeah.
Great job though. It was a really great case.
Thank you.
All right.